which will be chaired by Dr. Rama Gogia. She is professor and consultant at VMMC and Safdarjung Hospital. Her area of interest are pain and palliative care and obstetric anesthesia. I welcome you, ma'am, on behalf of RML Hospital. And Dr. Ganga Prasad is professor at Department of Anesthesia, Pain Medicine and Critical Care at AIIMS. And his area of interest is pediatric anesthesia, regional blocks, and difficult airway. I welcome you, sir. So today, this session's first speaker is Dr. Nishkarsh Gupta. He's additional professor at AIIMS Delhi, and his area of interest is airway management, skill training, onco anesthesia, ultrasound guided regional blocks. So he has so many achievements and publication in his CV. Good morning, sir, and I welcome you, sir.
So I'll be discussing about rehabilitation. Rehabilitation is something which is very important nowadays, and it is an important question if we talk in that sense for paper 4, for which this 4-day conference is being held. I first of all take this opportunity to thank Dr. M.D. Kaur and Akhilesh for giving me this opportunity and present for rehabilitation. So this is the overview of the topic. So I'll be discussing this under following headings. So we'll discuss about what is rehabilitation, how it is different from rehabilitation, what are the interventions as anesthesiologists we can do, when should we start, and what are the outcomes, and what are the limitations and future of rehabilitation for us. So rehabilitation is a complex process. Basically, it is a kind of cancer continuum of care. It starts from the time of cancer diagnosis and basically involves physical, psychosocial assessments at the baseline level, identify the impairments, and provide interventions that will help in improving those psychosocial issues and reduce the severity and functional impairments. So if we talk in simple terms, basically they are the interventions which are done before surgery and help to improve the patient outcome. So the idea is that we need to utilize the preoperative time and optimize physical, nutritional, emotional, medical, and pharmacological conditions with the intent to improve post-operative functional capacity and overall improve the morbidity associated with the medical and surgical condition. So how it is different from rehabilitation? Rehabilitation, as we know, that the process or the surgery is already done. And as healthcare services, we try to help the person get back to improve skills and functioning for daily living that have been lost or impaired because of the procedure or the event. In rehabilitation, it is a time-based process that includes not only those assessments and interventions which are initiated prior to the treatment to improve outcomes. So we can see this is the continuum of care. So we have rehabilitation, we have surgery with enhanced recovery program. Rehabilitation has an important component of ERAS. I will not be discussing about ERAS because we have a full lecture by Dr. Umar following this. And then it comes the rehabilitation. So it is a full thing we are utilizing for improvement of patient care. So as we know, in the preoperative period, patients are in a better condition. Since we are waiting for surgery to occur, so they have enough time to improve the condition. These are the interventions which can eventually be continued in the post-operative period, and patient is well versed with the process, so it is much easier for them. Compliance of the patient is better because though they know they are undergoing a major surgery and they want to do it, and we can involve the family and educate them for the same. Whereas in the post-operative period, for which we are actually using rehabilitation word, the patient might be in fatigue, there may be a healing which is going on. So as a surgeon, you may be concerned about disturbing the healing process. The anxiety levels are much more. And there may be some other treatment which is ongoing and you may not get enough time to further improve the condition. So essentially, both are equally important. And now the stress is on rehabilitation. And it has been seen that it actually improves the post-operative outcomes. So now coming to the need of rehabilitation. All of us know that cancer patients are malnourished. They have cancer cachexia. They might be related pain, and there may be a patient may be on some medications. And many of them receive adjuvant chemoradiotherapy, or before the surgery, they receive chemoradiotherapy. And all these drugs are toxic and they have effects on the systemic level. Traditionally, rehabilitation has been described for cancer surgeries only, and now it is expanding its horizons for other surgeries. However, considering the data is more on cancer surgeries, I will be limiting my talk to effect on cancer surgeries. But the role of rehabilitation is practically in every possible surgery. So this is the effect of chemotherapy. I will not into details. This is just to show that all the drugs which are given in chemotherapy are toxic, and various systems are involved including pulmonary, cardiac, liver, and nephrotoxicity. And we need to be aware of the toxicities, and we need to act accordingly. Well, it has been seen that mortality in major cancer surgeries may be as high as 50%. This may be because of tissue trauma due to surgery, decreased physical activity. There can be a prolonged starvation, associated psychological stress, and the age of the patient. And this tends to lead to rapid decline in functional capacity, reduced recovery, and increased post-operative complications. So there was a systematic review which was done, published in Surgical Oncology in 2013, and it shows that pre-surgical exercise interventions, or rehabilitation, what we call nowadays, has the potential to improve patient outcomes and should be routinely done. So now the next question arises, what are the components of rehabilitation? So the components are very simple. All of us know that. So the important thing is they are very simple, but yes, they yet need to be done because most often they are ignored because we don't give enough kind of weightage to their possibilities of improving them. So broadly, we can have functional, basically medical optimization, which as anesthetists we do in the PEC clinic, the exercise prescription, depending upon the patient's kind of structured programs for the patient condition. Then lifestyle modification like cessation of smoking, alcohol, improving sleep hygiene. Then stress management strategies like relaxation therapy. And we need to improve the nutrition by dietary modifications. So now we know there are a lot of components, with the simple ones which we need to do, but when to start actually? So what is the optimum time that we start rehabilitation? So basically, whenever the patient comes for first visit to the hospital and is planned for a major kind of surgery, that's the time that this should be started. And normally we have enough time, about 4 to 6 weeks before the surgery is being done actually. So those time can be utilized to improve overall condition of the patient. So we record the basic anthropometric measurements like weight, height, lean body mass, and body fat. And depending on that, this program can be customized. And as we know that it is a multimodal kind of approach is needed. So we need anesthetists, surgeons, perioperative physicians, geriatricians to be on the same page. So they will be sitting together, deciding on the patient's condition, and the condition can be improved by what all factors. And then that kind of customized prescription needs to be given. And a lot of involvement of dietitians, physiotherapists, exercise physiologists, and clinical psychologists is also needed. So the goal is to stratify perioperative risk and formulate a patient-focused multimodal rehabilitation program. So what is medical optimization? So all of us know that we have a lot of patients are coming with a lot of comorbidities, whether it is diabetes, hypertension, and the list is endless. And most of us who are getting anesthesia, giving anesthesia for these patients, so some kind of comorbidity is there. And it is well known that if it is unoptimized patient, it may lead to delayed recovery, it may lead to post-operative complication, it may lead to increased cost of medication, it may lead to psychosocial and behavioral problems, increase the length of stay, overall hospital stay, and may increase mortality. So these are so many problems which are associated with unoptimized patient. And it is very important for all of us to optimize the patient best for the possible surgery. Moreover, the patients might be on some kind of substance abuse like nicotine and alcohol, and these are known to cause a lot of problems in the perioperative period. So depending on the kind of risk factors and the patient's other risks, so we need to risk stratify the patient. So we have various scoring systems like P-POSSUM score, which may help us to predict mortality, morbidity, the Lees index, cardiovascular risk calculator, shuttle walk test, CPAD, and general surgery, acute kidney injury risk index. So all of these can be used to risk stratify. And depending on the risk status of the patient, we need to introduce measures in the preoperative period to improve or reduce the risk. Well, regarding smoking and alcohol, they have to be stopped as far as possible. Even as low as 2 weeks of abstinence is good enough. It improves the immune competence and may help in wound healing. The best effects are seen if we stop them for about 6 to 8 weeks, when the pulmonary function also returns and the overall outcomes are much, much better. For alcohol, bone regeneration also improves if the within 6 months. So basically, we have to stop them as far as possible. Moreover, we should take this as an opportunity to counsel them regarding the side effects of smoking, alcohol, and other abused things, and that will help them to stop them as well. So the next big question arises, as I told, we have a rehabilitation programs mainly for cancer surgeries. So first thing, surgeon will say we don't have enough time and we should we actually go for surgery or should we wait, whether it will may lead to worsening of cancer. So this is an important question, and so we have this acceptable waiting times for cancer surgeries, and this is important. So as you can see, most of the surgeries of cancer which we are getting this done, known as suspected invasive cancer, the optimum decision to consult to decision time or T1 is 14 days, and decision to operate is 20 days. So basically, we have about at least 2 to 4 weeks, and believe me, that is enough time for us to overall improve the physiological condition of the patient, improve its nutrition, improve the exercise capacity, and this will help them in the perioperative period. So once the patient comes for the surgeon with symptoms, during the workup time, mostly they will take about 2 to 4 weeks, and this time should be utilized optimally for rehab. So now exercise programs are one of the important components of rehabilitation, and our focus is on structured exercise programs. They are needed because cancer is associated with deconditioning. So we have associated fatigue, sedentary lifestyle, medical comorbidities, age, cancer itself, surgical condition, and associated with chemotherapy, which we give. So all these lead to a lot of deconditioning, and this deconditioned patient may not tolerate a major oncological surgery. So basically, we need to initiate preoperative exercise programs, which involves regular physical activity incorporated into a planned and structured program. This will be included but not limited to cardiovascular or muscular fitness and targeted exercises. The idea is to basically decrease insulin resistance, increase lean body mass to body fat ratio, and skeletal muscle adaptation. The preoperative training as muscle strengthening exercises can also be done. These include exercise daily, walking for about 1 to 2 kilometers per day, bicycling for about 30 to 45 minutes. Deep breathing exercise, which is very simple, can be used. Simple parameters can be used, taught to the patient. Yoga or pranayama, and all this improves the overall condition of the patient. Well, we can measure the exercise intensity by measuring the heart rate. Basically, moderate intensity means 40 to 60% of age predicted maximum heart rate is achieved. And for vigorous intensity, about 60 to 85% of maximal heart rate is achieved. And there's a box scale, which is subjective measurement of estimating individual's heart rate based on perception of how strenuous the exercise is by the patient. And 6 means no exertion at all, and 20 means maximal exertion. A perceived exertion is basically between 11 to 16, which means that the stress is at least enough to show that patient has been exerted to the capacity. Well, these structured preoperative exercise programs, they tend to improve about the condition of the patient by 16 to 97%. In addition, emotional support and personal programs are key in improving the condition. We have to set daily targets. A positive reinforcement by regular feedbacks and follow-ups are also needed. Well, a word about 6-minute walk test. It requires the patient to walk the longest distance possible in a set interval for about 6 minutes through a walking course, preferably 30 meters long. And the longest distance the patient travels has shown to have a medium to high correlation with actual VO2 measured at the peak level of exercise testing. So basically, this is a calculator you can get online, and I have put in some dummy details. So select the gender, the height, age, and the weight, and add the distance traveled, and it will give you what is the expected 6-minute walk test and what is the patient's condition with respect to the expected benchmark and what is the lower limit. So this, you need not memorize the formulas, but yes, you must know that this is important and this needs to be done. More importantly, now we have kind of objective machines or equipment to assess the exercise program of the patient. So we have cardiopulmonary exercise testing machines. So you may have a treadmill-like or a cycle ergometer-like of equipment. It basically evaluates the exercise response across entire range of functional capacity and identifies what is the limitation and suggests what kind of training or rehabilitation targets can be set. It is delivered about 3 times a week for 6 weeks in hospital settings. And the idea is to increase the anaerobic threshold and or maximum oxygen consumption of the patient. Another important thing is a lot of cancer patients are anemic and kind of hematinic. Optimization is needed. All of us know that iron deficiency can be seen in about 70 to 80% of these patients. It is often undiagnosed. poorly managed and further exaggerated because of the blood loss during the surgery. So the blood transfusion is associated with increased cancer recurrence and mortality. So on one hand, we have a kind of low hemoglobin situation, and we are wary of giving blood in the patient because of other issues like cancer recurrence and mortality. So we need to optimize the oxygen capacity in the preoperative period by trying to address the anemia, giving iron, and also improving the exercise tolerance. So IV iron should be given to replenish the stores. So, and it tends to improve overall CPET capacity of the patient and health-related quality of life of patients. In addition, B12 and folate deficiency, if there, should be corrected. However, there is no role of erythropoiesis stimulating agents in these patients. So if hemoglobin is less than 10, we should give single dextran-free IV preparation, ferric carboxymaltose, 750 milligram, and we can repeat if needed for a complete and rapid response of iron stores. In addition to anemia, we have nutritional deconditioning of the patient. So we have malnutrition in patients in up to 60%, which may be because of the malignancy, inflammatory markers, GI abnormality, nausea and diarrhea associated, and obstruction because of the tumor, and some chemotherapy or other drugs patient might be on. And this may lead to increased postoperative complications, delayed wound healing, prolonged hospital stay, readmission is increased, and you may have increase in the postoperative death. So a lot of problems are there because of malnutrition, and we need to address it. So basically, it has been seen that 2 out of 3 patients coming for GI surgery are malnourished. They have 3 times risk of having complication if they are malnourished at the time of surgery, and 5 times more risk to die than well-nourished patients. However, only 1 in 5 have a formal nutrition screening process, which means it is often neglected. And 3 out of 4 surgeons or caregivers believe that perioperative nutrition tends to help the patient in reducing morbidity. It helps to save a lot of costs associated with the process, and also improves the condition of the patient. However, only 1 in 5 patients receive any preoperative nutritional intervention, and this needs to be improved. So a simple way of assessing is we have to check the BMI. If it is less than 18.5, then we have to check for any unplanned weight loss more than 10% in past 6 months. Then you see, have you been eating less than 50% of your normal diet? If any of one of them is yes, and or it is associated with albumin less than 3, then preoperative nutritional score suggests that preoperative nutritional screening is needed. So any one of the 3, with or without albumin less than 3, is an important indication to start screening and initiating preoperative nutrition therapy. So we need to assess with points which I discussed. Then if they are at high risk of nutrition, then we need to visit the dietitian. We start on a nutrition therapy. And once the weight is stabilized, there is again, we have increasing trend of albumin. We need not wait for albumin to normalize, but increasing trend is more important. Then we can plan for a surgery. So these are the screening tools we have. So we have malnutrition universal screening tool, malnutrition screening tool. Then we have subjective global assessment, and NRS. So a lot of them are there. So any one of them, you can use them to assess, and this will help to improve their condition. The next question comes is whether we should give enteral or parenteral. So as a dictum, generally enteral nutrition is always preferred because it is better tolerated, improves the immune function, maintains the GI barrier, and overall it stimulates hormone secretions. However, in conditions when enteral may not be possible because of the GI tumors or other reasons, patient's tolerance is not there, then we may opt for a peripheral parenteral or a total parenteral nutrition. And if enteral is not possible, then up to 7 to 10 days before surgery, initiation of parenteral is recommended for severely malnourished patients. So before surgery, we have to do screening of nutrition. If there's a problem, then we need to start with high protein with 1 to 2 grams per kilogram per day. On the day of surgery, a carb diet needs to be given, clear carbs. So this will be discussed during ERA's lecture. And then after surgery, we need to start on real food post-operative period and focus on proteins and not calories. And this needs to be maintained. A word about immunonutrition. So immunonutrition has come up recently, and a lot of supplementation has been suggested for improving the perioperative condition. So conditionally, essential amino acids like glutamine, arginine are important, and they tend to preserve the small bowel function, preserve T lymphocytes, and improve the responsiveness during major surgery. Omega-3 fatty acids have been shown to improve anabolic and immune modulatory effects. So they should be given in all major gastrointestinal surgeries. Data is limited and dosage is not clear. However, whatever data is there, it tends to suggest that it may help to reduce complications and specifically reducing wound infections and length of hospital stay. So anxiety is also a component. So what are the strategies to allay anxiety? So basically, psychological distress we know may lead to immune dysregulation, impaired wound healing, more post-operative pain, and prolonged functional recovery. So methods like deep breathing, relaxation, yoga, and music therapy tends to help. It also enhances and reinforces patient motivation to comply with exercise and nutritional aspects of intervention. And they should be done. They're very simple things, and they do help in the post-operative. The most important question is, what is the optimum duration? So if I have 1 week, is it the time to start, or should I have at least 2 months in hand? So that becomes important. So all of us know, so whatever we have at our plate is as good. So up to 2 to 6 weeks, structured exercise protocol tends to improve cachexia, mycopenia, sacropenia. 6 weeks for nutrition. If you have less time, we can go for parenteral. So about 6 to 8 weeks for optimizing respiratory system, optimization of cardiovascular system about 8 weeks, and anemia correction about 2 to 4 weeks. So basically, we have at least 2 to 4 weeks mostly, and a lot of the things starts reversing and things start to improve. So we should focus on improving the program, the patient's condition, using the pre-operative time for rehabilitation. So less than 4 weeks may not be sufficient for some of the targets, but more than 3 months may affect the compliance. So somewhere between 4 weeks to 3 months, depending on the condition, is the optimum time, and we have to balance that the patient's condition improve and overall complications also reduce. Adherence to rehabilitation is also important. The standard instruction booklets are given to the patient with a lot of content that what needs to be done. Patient needs to be contacted telephonically to ensure compliance with frequency, intensity, and duration of exercise and nutritional conditions, nutritional content which has been suggested to him. Now, once we have done the process, we have started rehabilitation program, improved suggested exercise, nutrition, and anxiety allaying program. So how do we measure the rehabilitation success outcomes? So one of the important metrics in the cancer patients is return to oncological treatment. So basically, cancer treatment is a complex kind of process which involves radiotherapy, chemotherapy, and surgery, and all of the three are equally important for overall success of the treatment. So return to intended oncological treatment is an important metric nowadays, and it is a measure of success of the procedure, what is being done. Then days alive, out of hospital at 90 days, complications and risk associated with the procedure done, hospital length of stay. All of these are important metrics which measure the rehabilitation success and outcomes. It has been shown that rehabilitation tends to improve the physical functioning, psychological functioning, cancer-related treatment compliance, treatment-related impairments are reduced, then unnecessary testing, time to recovery, hospital length of stay, at readmissions, all of these are reduced. Disability, mortality, all these are reduced. Overall improved quality of life and occupational function. So it is all plus for rehabilitation if it is done in time and should always be done. But there are a lot of barriers to it. So we need to have increased time spent on the patient. We need to ensure compliance of the patient. A multidisciplinary team is needed. Costs associated are needed. And we need to adhere to the recording process. So these barriers need to be addressed, and so that the process can be done seamlessly. Coming to the future of rehabilitation, we need more and more better studies on cancer rehabilitation and rehabilitation to further validate the findings. Well, increase in oncologists wanting rehabilitation care of cancer patients. Well, cancer rehabilitation and rehabilitation is part of the bundle care and should not be optional, and it should be a standard of care offered for all the patients undergoing oncological surgery. So take-home message is that rehabilitation is a novel concept that is distinct from pre-operative optimization. It includes modification of risk factors like anemia, malnutrition, smoking, alcohol, and should be identified in time, and appropriate interventions should be done. CPET is an objective quantification of functional capacity, risk stratification, and helps to guide rehabilitation program. It helps to expedite post-operative recovery of functional capacity, reduce complications, and reduce commencement delays in adjuvant therapy, and overall improves the outcome of the patients. Multimodal strategies are more effective, and we need to include the multimodal strategies along with specialty involvement for overall effective rehabilitation. And then we need to have further research to substantiate the role of individual components of rehabilitation in improving the outcomes. So before we end, there are some of the exam questions which may be asked to you in the exam, like how to assess the nutritional status of the patient in perioperative period, how we define rehabilitation, what are its components, preoperative preparation of patient scheduled for GI surgery with anemia, a short note on CPAT and 6-minute walk test, and similarly some major surgery, a patient which is a smoker and chronic alcoholic, and how do we prepare for it. You must remember that this is different from ERAS, and the answers have to be given depending on the question and not whatever you know. We have to be very careful and read the question properly and then answer in the exam accordingly. Well, thank you very much. So this is a new book we have come up, Clinical Anesthesia by Parash, which is customized to diseases prevalent in India. And we have added MCQs in the end for better understanding as well. This is my email ID and a mobile number and WhatsApp number. So any queries, you can always ask me through the email or WhatsApp. Thank you very much.
Thank you so much, sir. It was a wonderful presentation, packed with so much information into short time. And especially the exam questions were really, I think it would really help the students for upcoming exams. Thank you so much, sir. There are a few questions I would like to take up. Dr. Geeta wants to ask, are there any guidelines by Indian society as per the resources available in India?
No, not as of now. But yes, whatever little we can do. So I mentioned regarding simple things like nutritional improvement, anemia correction, exercise. You may not have CPAT machine, but you can do a yoga pranayam customized to patient's need. So those things we can do. Even for ERAS protocols, which will be subsequently done. So none of them want that everything should be done. So all things are practically may not be possible for the patient. So whatever best we can do, depending on the availability of things, that should be done.
Thank you, sir. That was really helpful. Dr. Rama Gogia and Dr. Ganga Prasad, sir, if you want to say something, our chairpersons.
Yeah. First off, greeting to all, and I apologize for my just delay, because I got stuck in MNC case, just a of time. Dr. Nishka, this was a wonderful presentation. The topic is new, and I hope everybody will start practicing in not only in this cancer case patients, but also in all major surgeries, and definitely it improves the outcome. And personally, I feel the nutritional and psychological aspect are really has a value, and this should be stressed at least on these two areas. This I want to say. Thank you, Nishka.
Yes, sir. Thank you very much.